Good afternoon and welcome to this NHS Clinical Commissioners webinar. My name is Julie Wood, I'm Chief Executive of NHSCC and it's my privilege to be chairing today's webinar. I'm delighted to hear that we have over 400 people who have signed up to join this webinar and we've got just shy of 300 people already online. So it's going to be a very busy and action-packed hour. But we've got a lot that we want to impart to you, but also give you an opportunity to ask questions. So as the slide shows, this is about troubleshooting the implementation of the COVID-19 Urgent Eyecare Service, the CUES specification. So a bit about etiquette. If you can, with so many people online, if you can mute your, make sure your microphone or phone is on mute. If you please can ask any questions in the question box that you'll see on the right of your screen. And if it's for a specific speaker, then if you please indicate that. We will try to get through as many questions as we can, but we may not get through all of them given there's so many people on the webinar today. The resources here that we've put a link to is the document that went out from NHS England to CCGs at the end of April, which actually includes the CUES specification, which a number of colleagues will be talking about. So next slide, please, Sophie. So this is what we're going to be doing. We're going to be doing some very brief scene setting about the CUES service and the specification. Next slide, please. And then we'll be getting into the case studies. And I'm delighted to say we've got 3 cracking case studies from across the country. So we're going to be in Cambridgeshire and Peterborough first, then down to West Hampshire, and then up to East Lancs and Cumbria. So delighted to have so many people on to both share their experience, but also for you to be listening. And then finally, on the agenda today, we're going to be picking up questions and comments from you before we finish at 3 o'clock. This webinar is being recorded, so you can listen to it later and the slides will be available too. So don't feel you've got to rapidly write down everything that you hear. You will be able to listen again. So without further ado, I'm going to now hand over to Colin Davidson, who's going to talk a bit about scene setting for us. So over to you, Colin. Thank you.
Great, thanks ever so much, Julie. I'm really pleased to be invited along today, and I'm just going to give a perspective from the optometry point of view. I think the others are going to talk a little bit more detail about the ins and outs of CUES, but I think as a scene setting during the pandemic, all routine site testing has ceased, and essential general ophthalmic services aren't urgent or emergency services. As we know, hospital ophthalmology departments have reduced all routine outpatient and surgical activity. So they only looking after services for high-risk patients and emergency care. So as a consequence, there's a risk that patients with urgent eye health issues will find it difficult to assess care. There's potential implications for their sight and long-term eye health. So we welcome the clarity that NHS England has provided on how urgent eye care can safely continue during the pandemic. We're pleased to see the recognition of the role that primary care optometrists can play in delivering this care, and we welcome the requirement for joint optometrist and ophthalmologist clinical leadership. We support clear recommendations that primary and secondary care professionals need to work closely together to ensure that patients can access the eye care they need and minimising the risk of COVID-19 infection. The college has worked collaboratively with the Royal College of Ophthalmologists to develop and endorse the clinical pathways at the heart of CUES. We know in some areas there are already commission schemes in place. One particular example that springs to mind is the APCOS scheme in Kent, which is a community-based scheme run by optometrists managing a complex case mix. But we also recognise that in many parts of England, services similar to this are not yet in place. And where there is a gap, we would encourage and urge all CCGs to consider commissioning urgent eye care services as soon as possible to safely deliver urgent care in the community. We hope that the pathways and new ways of working and communication channels developed for CUES would be an excellent base for continuing transformation of eye care service across England after lockdown and beyond. And really, primary eye care providers within optical practice teams have a role to play in supporting hospital ophthalmology and other local primary care teams, such as GPs and pharmacists, in the immediate response to the pandemic. So thanks, Julie.
Okay, thank you very much, Colin. Now, Mike, over to you.
Thank you. It's very kind of you to invite me to participate. I think it's all clearly set out the principles behind CUES. From an ophthalmic perspective, when the COVID pandemic broke out, our first priority was to close down routine activity because of the need to balance the significant risk between visual loss and acquiring COVID infection. In terms of how we went forward from that sort of almost stop everything position, our next principle was to try and make sure that direct patient contact should take place with a clinician capable of making appropriate management decisions. And it's quite clear to me and my ophthalmology colleagues that optometry colleagues in the community are very capable of supporting us in this work of making sure that patients don't come to significant harm during the pandemic. And I think, as already alluded to, if there's anything good that can come out of this pandemic, is it should lead to new pathways, new models of working together that will enhance the link between optometry and ophthalmology in future. And I think the challenge in the immediate future is to make sure that the principles behind CUES and the CUES document itself is properly commissioned across the country. I think I'll stop there and let other people carry on.
Thank you. Before we go to Zoe, there's some comments coming through that people have no sound. So if people can hear us, could somebody just let me know that you can hear us? And Zoe, we'll go on to you now.
I can hear you, Julie.
Okay, brilliant. Thank you.
Thank you, Julie. So I'm Zoe Richmond, Clinical Director for the LOC Support Unit. And if we can move on to the next slide. So CUES is an urgent eye care service, and as Mike and Colin have already said, that it's been designed to improve access to urgent eye care within primary care. And the aim of CUES is to fully manage as many patients as possible within primary care, close to their own home. CUES is not CUES, it's not about providing sight tests or the provision of spectacles, and CUES is not minor eye conditions either, and I'm going to just touch on that a little bit more now. So next slide, please. So CUES is a new service. It was developed in direct response to the pandemic. It delivers care for people presenting with urgent symptoms, whereas a minor eye condition service is very much a routine service that delivers care for patients presenting with more minor eye conditions. CUES extends the scope of care typically delivered in optical practice, and I'll explain to you a little bit later about how that can be delivered. Minor eye conditions delivers care in optical practice, but working within the core competency of the practitioners within optical practice. CUES requires all patient episodes to start with a remote consultation, either by telephone or video consultation. And it also supports the networking of care across optical practices. So this isn't about an optical practice working in isolation, but it's about the capability across a group of optical practices across a locality. And that brings into it the equipment that's available within that locality and the clinical skill set as well. CUES delivers ophthalmology advice and guidance into optical practice. Now, we've had ophthalmology advice and guidance in many areas, but very typically it's delivered to general practice rather than optometry. And also CUES delivers remote prescribing where clinically appropriate. Next slide, please, Sophie. So we've got a couple of minutes just to talk through the CUES pathway. There's an awful lot of detail there, so I'll try and pull out the key points. Most patients that present to a CUES service will do so by contacting their optical practice directly. CUES starts with an initial telephone call, and this is primarily to make sure that the CUES service is the most appropriate service for that patient, or otherwise signpost them to a more appropriate level of care. All CUES episodes start with a remote consultation, and that remote consultation is delivered by a primary care practitioner. but it can be enhanced by ophthalmology advice and guidance and the support and advice from other primary care colleagues with higher qualifications, such as our independent prescribing optometrists. And again, it can be enhanced by remote prescribing. Between 60 to 70% of patients that come into CUES, we're expecting to be fully managed within that remote consultation. And patients will be supported through that remote consultation to self-care their condition, self-manage their condition. For those patients that do need a face-to-face consultation, one of the main purposes of the remote consultation is to gather as much information as possible so that we can appropriately clinically triage the patient to the most appropriate clinician. So it might be that the clinician delivering the remote consultation is the best placed clinician to deliver the face-to-face and fully manage that patient's needs, and that's entirely appropriate and provides continuity of care for the patient. But if that clinician that's delivering the remote consultation cannot fully manage that patient's needs within the face-to-face, then it's their duty to make sure that next step in the patient's journey, the face-to-face appointment, is delivered by a clinician who can fully manage their care. And that might be in the hospital eye service, or it might be in a neighbouring optical practice that has perhaps a different piece of equipment, or has a clinician with a different level of experience. And again, the face-to-face consultation, if delivered in primary care, can be enhanced by ophthalmology advice and guidance and remote prescribing. At any stage in the pathway, a patient might be referred into secondary care. That process, CUES requires the referring practitioner to make contact with the receiving practitioner to make sure that that referral process is managed and that patient is, the care delivered to that patient is delivered in the most efficient and effective way so that all the care can be delivered in a single patient contact. And on that, I'll hand over to the next presenter.
Okay, thank you. So now we're going to do a very quick poll. We've got 366 of you actually listening in at the moment. Can you please go to the poll section on the right? We'd just really like to know who we've got on. So can you please select one? Are you from CCG? If so, can you let us know which one in the chat box? Are you an optometrist? Are you an ophthalmologist? Or are you somebody else? So if you could just respond to that poll, then we'll have a much better view as to who we've got listening in today. While you're doing that, I'm now going to hand over to our colleagues from Cambridgeshire and Peterborough, who are going to talk to us about their experience. So we've got Simon, Alison and Dan, but I think Simon, you're going to be doing the speaking on behalf of you and colleagues in Cambridgeshire. So you're very welcome. Over to you.
Thank you. Next slide, please. Can I have the first slide, please, Sophie? Marvelous. So Dan, Alison and I started work on this in the middle of March. Dan sends his apologies. He's a consultant ophthalmologist and he's busy in a clinic at the moment, but Alison and I are here. The reason I mention the fact that we started in the middle of March is because this was really before any guidance, any national guidance. And so you may detect some subtle differences between what we've done and what's now being recommended nationally. And we're happy to take questions on that. Now, the reason I've put up this slide about the rationale is because back in the middle of March, we believed that we were going to get a lot of resistance to this. After all, you probably all know that's been the case for a number of years. So we thought long and hard about what the wins were for primary care and secondary care and optometrists. And I'd add to those three bullets one which became apparent as soon as we started thinking about recovery, about what we're going to do when we came out the other side. And that's, we wanted to avoid having a huge backlog when the crisis was over. And the wins for optometrists were quite interesting. So there was a funding issue which we needed to address. So we created a version of a block contract to pay each practice effectively what they would have been paid for the same period last year. And that was seen as fair and generous, and it was easy for us, once we got our finance people to agree, Can you still hear me, everybody? Good. So once we got that sorted out, then the next one was PPE. Unfortunately, our CCG had set up a very efficient system for getting PPE out to the right people. So that was addressed as well. Next slide, please. I won't talk you through this. I'll give you a 30 seconds to have a read of it. But basically, we wanted to make sure that the governance was 100% right, that our trusts were happy with the process, hence bullet 2. You can see that we put that in, and there was reference to it earlier during this webinar. But actually, in practice, once people realized that the system was working well, we're effectively using bullet 4, and GPs were referring direct to the optometrists, who, again, as was mentioned earlier, have always been able to get consultant advice if they needed, the ANG aspect of this. Next slide, please. And the whole of this text here comes directly from Dan Hornan, our ophthalmologist, who added this in. We hadn't really thought much about it, but of course, in terms of backlog and workload, this was extremely useful to the trusts if we were able to take this on, and so we did. And it's an important part of the service, as I think you'll see from the data that we're about to show in a minute. Just give you a little while to check that. And next slide, please. So this is, if you like, the activity. As I said, we started working the middle of March. There was remarkably little resistance. Everybody could see it was a good idea. So that's for the whole of April. Those were the patients we saw, and that's where they came from. And last slide, please. And these are the outcomes. And as you can see, the number of patients who are adding to the backlog is 8, and that's a lot better than 169. I hope you'll all agree. That's everything from us. Look forward to your questions.
Sorry, I think I was on mute. So from Cambridge and Peterborough, we'll now go to Hampshire and the Isle of Wight. Hello, Cheryl, over to you.
Hello, thank you very much for inviting me. I think probably go straight to the first slide so that I can talk us through the principles across Hampshire and Isle of Wight. This is very new, and as we've heard, it's not just a simple transfer of MECS to call it now a CUES service. So what we had to do as a system is core principles are coming up the centre of the pyramid there. Our core principles around designing things is to try and make sure we agree things once and do things collectively, but also maintaining that we have a localised feel and a local approach. The MECS, the CUES is a CCG commissioned service and funded by CCGs and to be implemented by CCGs across the local system. But the delivery mechanism could be, we have found in a number of different options of thinking how we work with the local health economy and the specialists within the health economy to deliver an equitable service across for our patients. That might be through the optometry practices, and I'll show in a moment that that's largely how we are looking to do it, or it could be through a community provider or an independent sector provider working in collaboration with community optometry, or indeed, as in one area we have, it is a really innovative secondary care pathway which was already in existence. But the key things we found is maintaining the relationships with the hospital eye services, building on what we've already got, and the delivery principle remains as set out really in the specification. Next slide, please. So just a flavour of Hampshire and the Isle of Wight. We're right down at the bottom of the UK, and we have all of our acute trusts have an urgent eye service, or indeed Southampton we have an eye casualty department, which has been well established, and of course patients and the public know it's there. So across West Hampshire and Southampton City, we had commissioned an enhanced service, a MEX service, as well as other enhanced services for optometry in the community, including things like discharge from hospital, rapid assessments, follow-up after cataract surgery. So we were in a very strong position across Southampton City and on ourselves in West Hampshire. And our intention, having reviewed the CUES specification, is to move our MEX element, which was perhaps a little bit more stretching than some MEX, across to the CUES, which has helped with thinking about the funding for this, and also who is going to deliver. In Southampton City and West Hampshire, we're very much relying on our community optometry practices to be the delivery mechanism for this, which is sort of the vision set out within the specification. Our colleagues in North Hampshire already commission a pairs service, which is obviously a more individual practice-led service. And following the review against the CUES specification, they are very much going to, or their intention is to move to the CUES specification and do a contractual variation. We're really, really lucky in our area that we have already tested the market and got a prime provider working with the majority of our optometry practices. So it's actually quite easy to convert some of our contractual mechanisms. In Portsmouth, we have got confirmed a high degree of the core principles of the specification is already being delivered as part of the urgent care pathway put in place in Portsmouth Hospital to take account of the COVID pressures. None of this is fixed in stone. We recognise that as we go through the COVID response period and also beyond, which this specification takes us, then you know, things may need to move. We may need to reevaluate how things are delivered in the community. And a final area, not least important, is the Isle of Wight, because historically they haven't had an enhanced service, very much been considering one and how that might work with their acute trust. And this has given the emphasis to actually move that up the agenda to enable, again, to work with other providers across the area and work as a collaborative commissioning body to rapidly put something in place with community optometrists supported by the acute trust for the island, and we're expecting our whole system to go live in the next week or so. Okay, next slide, please. Thank you. So some of the bumps we've hit in the road, the contractual issues, having a very mixed economy of how we've done this or had an enhanced service utilising the community optometrists. Having a mixed economy of how we contract these things has meant that for some of us it's been really a fairly easy contractual change, just assuring ourselves that the specification requirements are being completely met by our prime provider, and then it's a simple contract variation. For other areas, it's a little bit more mindful of the commissioning and contractual regulations, procurement regulations, so that we don't get ourselves into any hot water by awarding a direct contract to X but not having tested the market. We've been working very closely with our procurement service advisors and are very aware that we have emergency measure powers that we can actually call on to have a really sound rationale as to why we need to direct award. This is not something we're hanging around with. We can't hang around and go through a full tender process. So where we have got providers that can deliver, let's get on and get it delivered. Funding, always a tricky subject for us poor old CCGs who've not got any money. Where do we find the funding for this? There's nothing coming centrally, but actually there is a lot of opportunity in thinking about what the CUES or post-CUES contract might be able to deliver around system transformation, and building your business case should be pretty straightforward, and certainly I'm sure colleagues will be happy to share how they have funded enhanced services. The other key thing we chewed over to begin with was the local differences of how pathways needed to ensure that we didn't have equity or inequity of access to the urgent care pathway. And I think probably the core message I would give is keeping it local, but thinking strategically as a system on what are the core principles that we are trying to achieve here. The other tiny message we picked up on was the perception of value, and that needs to break down the barriers of secondary care usually provide these pathways, when actually we've got a very capable and experienced workforce in the community. And this has really given us the emphasis to think about, for the long term, how do we do things as a system. And like my colleagues, I'm very happy to take questions towards the end.
Great, that's really good, Cheryl, thank you. So now we're going to move up the coast to Lancashire and South Cumbria to hear from Donna, Katie and Alan. So over to you, colleagues. I think you're muted, Donna. Can't hear you at all.
Hello.
Can hear you now. Okay.
Hi Julie. Just letting you know, I think Katie Rimmer, who was supposed to be updating on the Foul Coast, is having trouble attending. She can't get into the webinar.
Okay, right.
So I'm not too sure whether you want to move on to the Pennine Lancashire element for myself.
Okay, yeah, let's do that then.
Okay, thank you once again for inviting me. Just to give an update of where we are in Pennine Lancashire with regards to the CUES service specification. Just a bit of a background. In Pennine Lancashire, we have had a MEX service delivery now in place with our primary eye care service since 2015, alongside a number of other enhanced services. Back in as COVID started to emerge, straight away by the 25th of March, ourselves and primary eye care had already put in a contingency plan already in place, and that was to deliver an element of urgent MEX services with obviously a reduction across our optometry practices. In Pennine Lancashire, we roughly have about 49 optometry practices, and this was now going to be delivered from around 22 practices. During that contingency plan, we then embarked on some discussions with NHS England and LOCSU providers with regards to the CUES specification that was then developed, and we then entered into discussions to how we may move forward across Lancashire and South Cumbria to deliver something more in a Lancashire South Cumbria footprint. Like I said, whilst we've already got an urgent MEX service in place, it was something that was quite interested in embarking and understanding what other people's thoughts were with regards to the service specification. And especially for ourselves and my colleagues over in Pennine Lancashire, was looking at the introduction of the OCT and the independent prescribing element, which for me was the additional part of what I'd already got in place with regards to commissioning a service in Pennine. From there, having entered various discussions to understand the delivery of the CUES specification and what that would mean to us, and looking at the benefits that we could possibly potentially see from that, and also looking forwards with our trust colleagues about how we may start to look at recovery coming out of COVID, and looking at obviously around the demand and the possible of utilising some of that capacity within our optometry services is something that we've been very keen to look at as an opportunity. So I then did an options appraisal with benefits, risks and opportunities, and for ourselves the opportunity around exploring and piloting the OCT image transfer to embrace new technology going forwards is a real leap of success in our area, and this is one area that we were extremely keen to take on board. So from a commissioning perspective, I have held numerous discussions with our local acute trust. Although we have a prime contracted model with our acute trust, it is them who actually subcontract the primary eye care services. However, we do have an extremely very good working relationship, and maintaining those relationships going forward is what enabled me to put an options appraisal forward to them and have quite a number of discussions. And again, it then come down to around the payment, looking at the national guidance around payments onto our subcontracting providers, which has then been handed over to the trust to make that decision. Following a demonstration this Wednesday on the OCT and the file element transfer for the images, there will be a decision made going forwards whether we implement this service specification until the 31st of July. However, it is looking extremely promising, and from this, like I've said, I think it's really looking about how we may shape the future with optometry, working with optometry colleagues and secondary care colleagues, and maintaining those relationships going forward. Thank you.
Okay, thanks very much, Donna. Can we move on to Alan now? I think we're trying to get Katie back. So Alan, if you'd like to put your webcam on so we can see you, and also make sure you're unmuted. Hello. You're muted. No, still can't hear you.
How's that?
Perfect.
That's better. Right. Okay. Thank you very much, Julie. From an NH England perspective in the Northwest, we have a dual role in this area. We are both supportive of CCGs and we also have an assurance function. Obviously, NHS England does not commission the CUES service. That is down to local assessment and need by the CCGs. Some, in fact, the majority in Cheshire and Merseyside are looking to commission a CUES service or already have done so. To encourage the others along, what we've done is we've promoted the service to CCGs, commissioning leads, and we've been very supportive. We've offered them clinical input from our local eye health network chair and our other optical advisors within the area. That primarily is to actually allow them to see the benefits of the service. We've engaged with other local stakeholders, CCGs being an obvious example, LOCs and contractors, to promote the service further, to help everybody understand what is actually required within the service. On an assurance side, where CCGs are not commissioning the CUES service, we're asking them very clearly, what do you have in place to actually look after these patients? We simply can't have no service being provided because potentially we have sight-threatening conditions here. So we're seeking those assurances whilst being supportive at the same time. We're actually going back to the CCGs and say, okay, you've chosen not to do this. Tell us what you've got in place. we need to make sure it is actually appropriate. We're currently also working on a comms pack to alert patients that this service is going live in a particular area at a particular time, and we will have a final draft of that ready to go out shortly. Essentially, that's what we've been doing from an NHS England perspective in Cheshire Merseyside.
Okay, that's great, thank you. So, Katie, have we got Katie Rimmer? Have we managed to get on the webinar? If not, then we'll crack on. We'll move on to the questions. So, as I'm sure you can imagine, we've got a lot of questions that have come in. If I can try and point them towards various panelists. We've also had some pre-received questions, which again we will try to point to. So Cheryl, there's a couple of questions to you. Have you given notice on the MEX contracts, and are you happy to share your business case with others?
Yes. What we have literally, I mean, as I say, this is and so it's great to be doing this webinar. We have our intention is to serve notice on our current MEX contract with our prime provider, and then reissue the CUES specification. We can do that because all parties are in agreement, and that has come about with relationships with the provider, our local LOC and LOCSU, and other individual clinicians. So that's how we're doing it in Southampton and West Hampshire. We are also intending that our colleagues on the Isle of Wight will piggyback onto our contract as they're working through their business case arrangements at the moment, so that we will be able to launch as one, or possibly in a slightly staged way.
Okay,
so,
thanh you.
We're happy to share our business cases, definitely.
Oh, super. Well, if you can, we can have a grab hold of that and then make available a link. Final one to you. North East Hants and Farnham isn't mentioned. Is that because nothing's happening there?
The North East Hants and Farnham, I have a colleague who is working in that system. We have a weekly telephone conference to see where everybody is at. I'm not really close, but I can certainly put colleagues in contact and provide the link if that's needed, and people can follow up directly.
Okay, that's great, thank you. So we had some pre-submitted questions about money, funding, pricing, not surprisingly. So between sort of the three case studies, I don't know who wants to have a go. So there's some questions about interested in any examples of pricing for the service. Appreciate that that's for local determination, but a range of pricing would be beneficial. Can anybody share any information about pricing, how you've done it? There's another one around telemedicine appointments and how that's being funded as well. So Cheryl, anything from you before we go to Cambridgeshire?
We have we were in the fortunate position that our local tariffs were very similar to what we agreed would be an appropriate tariff for the CUES. So that was acceptable to our prime provider, even including the enhanced aspects of the specification. So from our perspective, financially it's worked out quite well. I can share the tariff structure and explain that as people want.
Okay, so maybe we'll grab that and make that available. So there's a question about what specific higher qualifications do you require optoms to have for this service? So maybe Colin, Mike, or anybody else want to come in there and respond to that on that question?
Julie, thanks. Higher qualifications. I mean, a lot of the cases that we're anticipating can be dealt with by all optometrists. I think the advice and guidance aspect of it is when they would then reach out to a colleague who maybe has an independent prescribing qualification, or to ophthalmology. I don't think it's going to be a requirement that everyone has to have a higher qualification to take part in this scheme. It's envisaged that it's really all optometrists, but seeking further advice and guidance. And I think that's what sets this apart from MECS. It's able to deal with more complex cases, but do that in a way where there's two-way communication between different colleagues, maybe an ophthalmologist, maybe an IP optometrist. I don't know if Mike, if you want to add anything into that.
Yes, Colin, I agree with you. The issue is about network care. Fundamentally, the patient will not know what their diagnosis is, and they are likely to seek the first port of care, the first available person to talk to about their symptoms. And this may well be the high street optometrist, or it may be the eye department which they're already linked to. But if they come to the optometrist first using the CUES system, I think it's entirely reasonable that the optometrist assesses the situation by telephone first or video conference if that's possible, assesses for themselves whether they are likely to be able to manage the problem, give sensible advice on a face-to-face meeting if necessary, and then assess whether they need to also seek further help.
Okay.
Departments is making sure that when you are working on this CUES process, that you have established good links with your local eye department so that help is available immediately should it be necessary.
Thank you very much, both. Donna, a question for you from Pennine. What technology are Pennine CCG piloting for image transfer, and does this work with manufacturer's OCT machine?
Hello?
Yep, can hear you.
Can you hear me? Sorry, it's just come up saying that there's a network connection problem. The first question, what system we currently use in Pennine, Lancashire to manage our ophthalmology referrals from primary care and secondary care is the use of the Opto Manager system. The OCT element of the CUES specification is, my understanding, is an additional, it's called Opera, which links, it's a separate system, but it also links into ERS, which, again, thinking about innovation and technology moving forwards, if we're able to transfer OCT images and not just images, the full file, this is a real improvement across our region. This is yet to be tested. I have seen a demonstration, and this demonstration will also be taking place with our clinical leads on Wednesday.
Okay, that's great, thank you. So I've got a comment here. Some areas have CUES set up, the majority are not as well advanced. We're now 8 weeks plus into the current scenario. I wonder what we may have learned in order to have a coordinated response in the future. So maybe one to ponder on as we look at some of the other questions. I'm having problems. My system keeps freezing. I hope you can still hear me. There's another question that came in before. Can you hear me?
Yeah, sorry, it's Mike again. Just reflecting on that question about the future. The long-term goal that I think Colin and I are looking towards is that we establish very effective local networks between optometry practices and their hospital colleagues. And then this is not something we have to create, but is inherent in how we do things. And that's, to me, the ultimate benefit, if any, of this current pandemic, is that we get those measures in place so we don't actually even have to have this meeting in future.
Yeah, okay, thank you. A couple of questions coming in about the difference between CUES and MECS. So if CUES is different than MECS, then why would MECS need to be decommissioned, is one question. and another one what came in before, which was how do I convince the CCG that CUES isn't MEX? They're adamant that MEX is sufficient and that CUES isn't required. So, colleagues, Simon, Cheryl, Donna, any thoughts about those ones?
Well, I'll speak first on behalf of what we're doing in our local area. I think, firstly, to say we were in a strong position because we were already looking at ophthalmology pathways and transformation before COVID actually hit. So some of our plans for things we were going to do in the year, what we have been able to do is step things up around the IT, image transfer. You know, again, I would say we're very lucky in that the provider that our prime provider is quite innovative and taking a very proactive approach. Why do we need to decommission MEX? Well, the decision we've taken locally is we can see the benefit of the CUES in filling a lot of the gaps, where we've had a MEX for a long period of time and thinking about minor eye conditions and the move to getting patients to engage in different ways of managing minor conditions, not just eyes, self-management, what we can and can't or should and shouldn't prescribe, things that can be bought over the counter, etc. So we've very much seen CUES as updating our MEX and filling the gaps. So that's why we've taken with an agreed approach with our provider to stand down on one specification and stand up the next.
Okay, thank you. Simon, anything to offer from Cambridgeshire and Peterborough on this one? Or Alison or Dan? No? Any thoughts from the north on that point? Simon, are you coming in?
Yes, I am. I was muted and was being incompetent. Yeah, basically, I agree with what Cheryl just said there. Our MEC was really just minor eye conditions, unlike some MECs in other parts of the country. And we have no intention of closing that contract or disbanding them in any way. We're simply adding in this new functionality. Obviously, we're going to have to rewrite the service spec at some point in the near future, but this was all put together without the benefit of prior planning, without any contingency plans in place. So we just did it and got on with it. And now we've got a bit of tidying up to do. Do you want to add anything, Alison? You're still muted, Alison.
Can I just add in there, Julie, just to say that I think Simon makes a really important point there, that actually many minor eye condition services were already commissioned and they were being delivered whilst CUES was in the development. And whilst we published CUES, we didn't want to undo any of the excellent work that was going on at a local level, where minor eye condition services were already being adapted and were already evolving with lots of innovation that, you know, essentially moves towards the CUES principles. What I would challenge any local system that has a minor eye condition service commissioned is have a good look at CUES, have a look at the added value that it can deliver to your system, and then you know, you need to have a look and see what's the best journey. Is it to decommission the minor eye conditions service and recommission this service specification, or is it to evolve your existing service specification? There's no right or wrong there, I don't think, but it is about taking you along the journey.
Okay, yeah, thanks very much, Zoe. Yeah, that's great. So before we leave Cambridgeshire, Peterborough, Simon, will there be more details of the cases dealt with by the Cambridgeshire CUES service? You're on mute.
Yes, absolutely. Alison and I are collecting the data carefully, and we're happy to share that.
Okay, thank you.
At the moment, sorry, at the moment, last week, yes, Alison. Sorry, I keep disappearing. Sorry, I'm having real trouble with the technology here. basically, we've been asked by the hospital to do more last week anyway, because they've now said that they found it so successful that they want to work more closely with us in collaboration and get a lot more patients out of the system going forward to really work.
Okay. That's helpful. Thanks very much, Alison. Another question about quality control. How can CUES be quality controlled, i.e. minimise duplication of visits to optoms and hospital eye service? So reflections from anybody on that one?
Is that going forward, do you mean? So, or as it is currently?
I think it's as it is currently. This was a pre-populated question. I think Simon's, the chart that you showed, Simon, about the number of cases that are referred on is low. So I suppose that's part of the answer. But has anybody else got any comments to add to that one, particular one?
Just to say that this is an integrated service model, so this is primary care and secondary care working together, so that should, because everybody's working together across the patient pathway and across the system, that should avoid duplication, and the pathway should be developed in that way and implemented in that way. And also there'll be an opportunity to evaluate the service in a joint way. Mike and Colin talked about the clinical and joint clinical leadership, so there'll be a clinical lead in optometry and there'll be a clinical lead in the hospital eye service that will work together to look at the data and understand it and evolve the service.
Yep. Okay, thank you. A couple more on money. And
Julie, can I just add to that, please?
Yes,
from Pennine, Lancashire.
Sorry. Yep.
Just quickly with regards to the evaluation element, which I think is a huge key, because whilst we're embracing new ways of technology, video conferences, telephone calls for first appointments, etc., and then maybe implementing the OCT, evaluation on how this is for patients and how patients are accessing the service, as well as for primary care colleagues and secondary care colleagues, is key, and that's something that we will be picking up on extremely carefully before agreeing to do anything else with regards to our MEC services or moving forwards.
Okay, that's really helpful, thank you. A couple more on money. One was a plea, could we have a consistent price across the country, as we are trying to do this across the country, one for telephone video call and one for a physical face-to-face. And then another one that's asking about remuneration going forward, what will be offered per patient episode for optometric practices. So any thoughts about a consistent pricing across the country? Alan, do you have any thoughts from Manchester England perspective, or Richard or anybody on that one?
Can I just sharing my reflection. I suppose we have across Hampshire and Isle of Wight, we have had one model, one prime provider, and so we've worked within that lens of pricing, and there probably is some value from getting some guidance from NHS England and NHS Improvement around what is a fair price and how does that link to new contracting models. How do we work this into thinking about outpatient bundled tariffs as we go forward. So I think there's quite a few things to explore, but getting the remuneration right so we get a high quality service from optometry practices is really important. If we pay peanuts because we see a telephone contact or a video consultation as somehow being less value than a face-to-face consultation, when many of us know that actually teleconferencing is or telephone video assessments are just as time consuming and in many respects harder and need greater and wider skill sets to be able to do a good clinical assessment without actually hands-on with the patient. And I think this is something we need to think about outside of what we're just doing for CUES in the short term. In the longer term, having a framework around commissioning enhanced community eye services.
Okay, thank you.
Can I just say,
can I-
across the east of England, we did actually in our local area team start looking at reasonable amounts to be paid for services, CUES services. And so the discussions are already going on as to what would be reasonable across whole areas rather than individual CCGs necessarily.
Yeah. So maybe
Julie,
we need
can
to.
I just come in as well? I'd really, our members as optometrists would be looking for a fee that's realistic to cover their costs, and I think the point that Cheryl made about these remote consultations is an incredibly valid one. Having done a few of these myself, it's a skill. It takes more time, and I think we can't discount that as being of lesser value. So I think we would be looking for realistic fees, and the more realistic it is, I think the greater the uptake you would get on that as well.
Okay, that's helpful, Colin. Thank you. Somebody's commenting that there's nobody from London on this webinar. What's the situation with CUES in that region? So, Richard Everett, I don't know whether you want to come in and give an overview, if you can, about what the position is looking like from your perspective across the country. Can you add anything on that one?
So I'm not terribly close to the situation in London. I know that they are looking at implementing a CUES solution or equivalent of. I'm not too sure how close they are to that. There was a possibility they were going to be joining this webinar as another guest CCG at one point in time, but I'm assuming that they weren't quite able to reach an agreement in time to do so. And in terms of the picture across the rest of the country, there's always probably better place to give you an update from LOCSU in terms of the conversations we're having. But I understand as of last week, we were in discussion with over 80% of CCGs, and with about 45 of them from memory, we were in quite advanced stages of discussion. But Zoe, you can probably elaborate on that.
No, you're absolutely right, Richard. I think we've pretty much reached out and had a conversation with every CCG in England pretty much now. And we've got, so we're mapping the stage of this discussion as to early discussion. So the CCGs and the leaders there are just trying to understand what CUES is and what it potentially delivers to their system, to very advanced stages where we've had an intention to commission and is just moving forward with that, actually understanding who's actually going to be delivering. So there's good progress across the whole of England, and in London there's 5 ICSs in London, and all are having conversations at an ICS level. So we can quite happily update and provide a table of progress to support the resources following this webinar.
Thank you, Zoe. I think that would be hugely helpful. It is now 3 o'clock, so I do need to draw the conversation to a close. There are a number of questions that we haven't been able to answer today, but we will endeavour to get some answers to those questions after the webinar. As I said, it is being recorded and you will be able to see the slides as well after the webinar. So can I thank everybody for both listening in, huge number of you who have done that and contributed your questions, but can I thank sincerely all of our presenters from national organisations, but also local CCGs, to give some really good case studies to give you a good picture about what is happening across at least 3 parts of the country, if not all. So thank you once again. Thank you for your time, and I hope this has been useful for you to take forward discussions locally. And thank you very much, and bye-bye.